6 COVID-19 clinical care rounds focused on emergency medical services, patient care, and operations. I hope you all had a relaxing and uneventful holiday weekend. My name is John Kramer. I'm an EMS and emergency physician who serves as the director of the National Office of EMS, the National Highway Traffic Safety Administration. And I'm also the team lead for the EMS pre-hospital team of the HHS Healthcare Resiliency Working Group. The purpose of these sessions is peer-to-peer real-time sharing of COVID-19 EMS challenges and successes in patient care and operations. As the basis for these series, we ask the general question: if I'm an EMS clinician preparing to care for many COVID-19 patients, the clinicians I want to learn from are those clinicians who have the most experience. This is a voluntary public-private collaboration. Thank you to the multiple organizations who have collaborated on this series. It is not intended to be redundant or replace any organization's initiatives, but is intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. Special thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. We also appreciate the AAMC and NETAC for their support with these rounds. Upcoming ECHO COVID rounds currently are all scheduled for noon US Eastern Time. The Monday topics are EMS, Tuesday on critical care, and Thursday on emergency department. For the ECHO clinical rounds we've had to date, we have participants from all states and multiple international countries, predominantly physicians, nurses, and EMS clinicians. We have a strong interest in making this more interactive by engaging expert discussants who will introduce themselves shortly and participating in crowdsourced polling. We've received many pages of questions and apologize in advance that we're not able to answer them all directly. We have, however, picked out major themes for questions received and hope to cover some of these during today's session. I'd now like to turn this over to Dr. Struminger from Project ECHO for some logistics and other announcements. Bruce?
Thank you, John, and thank you to our guest presenters today from Phoenix and Houston, and to our expert panelists, and to all the participants who have tuned in. Just a few housekeeping items before we dive into the main topic. Hopefully everyone will see at the bottom of your Zoom screen a Q&A function. Please put your questions and comments regarding today's discussion in that Q&A function. We'll be monitoring that. Also in the chat function, if you've got technical or logistic questions, put those there. John will be asking a crowdsourcing question in a little bit. We'd also love you to put your reply in the chat to that open-ended question. These sessions and this session is being recorded, and your attendance is consent to be recorded, so thank you for that. Both the presentations and a link to the recordings, the presentations should be available through the most recent email announcement that you would have received from Project ECHO this morning, and they will be on our website, and we'll share the link to that along with a link to the recording. So there's a whole archive of the more than 40 sessions over the last 3 months that you can find there. Also, about 15 minutes before the end of today's session, we'll put a link in the chat for continuing medical education credits. They're offered through the University of New Mexico, where Project ECHO is based. That link should also be in today's email announcement from Project ECHO. We really rely on your feedback that we receive through the questionnaire that you complete to get your CME, which is instant. And so please take a few minutes to do that and get your CME. With that, I want to share the microphone with Sharon Van Aersdale to give us an update on the NETech webinar series. Sharon?
Yeah, thank you so much, Bruce. Happy Monday, if I can say happy Monday to everybody. My name is Sharon Van Aersdale. I am the program director of serious communicable diseases at Emory University Hospital and the director of education for the National Emerging Special Pathogen Training and Education Center. And it has absolutely been a privilege and an honor to be able to be on these webinars with Project ECHO. This really allows NETech to kind of do deeper dives into topics that come up during the conversations here. So as you guys are chatting, I'm taking notes to say what are areas where NETech needs to focus on next. This week is our planning week because we have several series coming up. So we are going to be doing a two-part series on long-term care with some case studies from individuals from long-term care, as well as a two-part series on surgical considerations. So please check out our website at netech.org for more information. Thanks, Bruce.
Great, thank you, Sharon. And I'm going to go ahead and give a plug for the AAMC Clinical Guidance Repository. Our colleague, Rosha McCoy, is usually with us, but I don't see her today. So I just want to remind all our participants that the AAMC has a wonderful COVID-19 clinical guidance repository, which they're constantly updating. And the URL is at the top of the screen there. So we encourage you to go to that site to keep up to date with clinical guidance. And with that, John, I'm going to hand the microphone back to you.
Thank you. In just a minute, we will introduce our panel of discussants. But for our crowdsourcing clinical pearl this week, and please respond to this in the chat box. As an EMS clinician, did you experience any unexpected or untoward events over the holiday weekend related to either COVID, protests, or mass gathering events in your EMS system? And when you respond, if you would, please indicate the country or area of the United States from which you're responding. So we'll be coming back to this crowdsourcing question, and we'll be doing some additional polling questions shortly. I'd like to now ask the panelists to unmute themselves if they would, please, and we'll do a quick introduction of those individuals who are participating in the panel. Dr. Cunningham.
Good morning, I'm Carol Cunningham. I am the State Medical Director for the Ohio Department of Public Safety, Division of EMS.
Thank you, Carol. Rob?
Hi, I'm Rob McClintock. I'm the Deputy Director for Fire and EMS Operations at the IAFF.
Thank you. Dan?
Hi, Dan Gerard, Vice President for the International Association of EMS Chiefs.
Thank you. Alex?
Thanks all. I'm Alex Azikov, an emergency medicine and EMS physician at Emory University, and I'm the lead for the National Emerging Pathogens Training and Education Center, lead for EMS.
Thanks, Alex. Paul?
Paul Bittinger, I'm an emergency physician and director of the Center for Disaster Medicine at Mass General Hospital in Boston.
Great, thank you, Paul. Doug?
Hi, Doug Kupas. I'm an EMS and emergency physician with Geisinger Health System in Central Pennsylvania and also serve as the state EMS medical director. I'm on as a board member for NAMSP.
Thanks, Doug. Dave?
David Gershner with Dayton Fire Department, and I'm the Regional MMRS Coordinator for West Central Ohio.
Thanks, Dave. Sharon has introduced herself. I'll ask Rick to introduce himself, please. Rick may have locked. Oh, Rick?
No, I came back. Yeah, Rick Hunt, Senior Medical Advisor, Healthcare Preparedness Programs, United States Department of Health and Human Services.
Great. Thanks, Rick. It's now my pleasure to introduce Dr. Garth Gaber, who is the Administrative Medical Director for the Phoenix Fire Department, Glendale, Arizona Fire Department, and City of Sunrise Fire and Medical Departments. He is a past medical director for the Arizona Department of Health and Human Services, Bureau of EMS. He's a graduate of the University of Nebraska College of Medicine and completed his residency training also at the University of Nebraska. Garth, welcome, and thank you for joining us.
Well, thank you for inviting me, and it's a pleasure and a privilege to be addressing all of you with such exemplary credentials. It's a pleasure. Thank you. I have no conflicts to report because I'm not shilling for telemedicine. I would have a conflict then, but I have none in the subject matter I'll be presenting. Do you want me to launch into the presentation?
Yeah, I'm sorry,
Oh,
please.
okay.
Yes, if you'd bring up your
Okay.
slides, and the floor is yours.
Sorry.
That's okay.
Garth, you might try stop sharing and then try again and just select your PowerPoint.
Okay.
We're seeing your full screen right now.
Okay. There we go.
Garth, we're seeing your Zoom screen.
I think it's coming up here.
Okay.
Sorry for the.
While Garth is pulling up the slides, I'll go ahead and introduce the other presenters that we have with us today, who will be sharing with us information on the Houston Fire Department activities. Dr. Kevin Schultz is board certified in both emergency medicine and EMS. He served as an assistant medical director for the Houston Fire Department for the past 8 years. He's also an assistant clinical professor of emergency medicine and the EMS Fellowship Director at Montgomery Medical School, the University of Texas Health Sciences Center at Houston. Also with him is Dr. Chris Soders, a board-certified full-time EMS physician, serving as the Associate Medical Director for the Houston Fire Department and has done so since 2003. He maintains his emergency medicine board certification and works for a national travel insurance company and event medicine company. Perfect timing, Garth. Thank you.
Okay.
Over to you.
Can everybody hear me?
Yes.
Okay. Well, when you're asked to talk in front of people who are specialists in the field, you kind of want to bring up things that are unique to where you live and where you reside and where you practice. And so this is my best effort to do that. There are some peculiarities to Arizona. Arizona is indeed peculiar in a lot of ways, and I'll get into some of that and our particular challenges. Obviously, you've probably all heard that Arizona is one of the hotbeds in the nation and for new cases, and I'll try and give you a picture of the impact of that on our public health infrastructure as I go through this. So I'll focus on the response in Arizona, but more specifically Maricopa County, which is seated by the city of Phoenix. The virus is truly bringing us to our knees. Now, Arizona is spiking, obviously, but the big question is why, because you can't answer or you can't offer remedies until you answer the question why. And if you looked at our epi curves, they really did not show any sort of peak prior to reopening, and I think that was I think that was part and parcel of why we're having our issues here and now. We didn't have the first wave that a lot of places, New York, New Jersey, you know, I could go through all of them. And so we didn't really suffer an initial wave until we reopened. I think when our public health officials and the governor shut down our state, that we initially thought, wow, this is, you know, this is kind of cool. We are working from home, our freeways are not so gutted with cars. And I think everybody thought that this was sort of a neat way to spend our March and April. You know, we're usually glutted with sporting events and outdoor events during those times, but the uniqueness, I think, kind of tickled people's fancies and people stayed home. But boy, once the gubernatorials, the gubernatorial social distancing and stay-at-home orders resolved, we were out there whooping it up like is part of our Wild West pioneer streak. So there's an error on this slide. I'll get to it here in a little bit, but this when I was putting this together in a quick fashion on the 2nd, these were the statewide figures for Arizona. We had 84,092 total cases. That particular day, there were 4,878 new cases, and that third figure is actually should be 33. I couldn't even read my own writing when I put it in the slide, and that's the number of deaths on that particular day in Arizona. I wanted to contrast that with the 16th, just a couple of weeks earlier than that, and our daily new our cases were only 39,097 for the entire state for the entire lead up to that point. So even there, you can see that we doubled in what, 2.5 weeks time. The daily new case rate was around 1,200. Now, new figures just today to demonstrate even more pain and suffering is that our total cases are up over 100,000 as of this morning, 101,441. We're adding about 4,000 new cases every day, and our total deaths now are 1,810. So a grim milestone passed today, an even more grim milestone probably in a week or two, the way it looks if trends hold. Also, our hospital infrastructure's starting to get really stressed, as you can see. We spent the plateau phase even before we peaked by accumulating ventilators, doing revamping of existing hospitals within the caveats of the Department of Licensure to increase our bed space and our ICU space. Our ED visits as of July 1st were 1,289 for confirmed COVID and COVID under investigation, which was a record on that date. ICU patients were 1,520 with 91% occupancy, and that was a record. Our ventilated patients, 807 on that given day across the state, and that was a record. The thing about the ventilated patients is that I want to emphasize our Director of the Department of Health Services, Dr. Kara Christ, and our Governor, Governor Doug Ducey, did a good job of getting ventilators into the state. So we don't have a lot of problems in that regard. The Maricopa County statistics sort of mirror the states. As you might expect, Maricopa County makes up about half of the population of the entire state. Maricopa County itself is larger than 4 states in the union. It's the 4th largest county in population in the United States. The Phoenix Dispatch Center dispatches for a territory that is the 3rd largest dispatch territory in the United States. So we cover a lot of ground. We have 4.4 million people. We were the fastest growing county as of 2018. I don't know if that still holds, but on July 2nd, we had 57,485 cases, about half of the total. As of yesterday, we had 61,993 cases, whereas we had 825 deaths on the 2nd of July. That 24, I'm sorry, it means nothing. That's one of my errors in the slide presentation. Just X that out. But as of yesterday, we had 840 deaths in Maricopa County alone. We socially relaxed over the kind of 10-day period from 5/5 to 5/15, and restaurants opened first, then probably bars did, health clubs, and so it was sort of a stuttering reopening. But as of the 15th, everybody was pretty much reopened in phase 2 setting. And because of the social relaxing since the 15th of May, our Maricopa County median age of patient has gone from 49 to 35, which is a precipitous fall. And so how does that happen? Well, 50% of our new cases are in the 20 to 44 age range, and only 10% of our new cases are in this 65 and over category. Well, that clearly confirms that our young folks are out, not socially distancing. We have a big issue with mask wearing. We had a relatively cool spring and early summer here in Phoenix. And when I say relatively cool, we were barely crawling above 100 degrees some days, but over the 4th of July weekend, we were safely in the 110 range. And so I don't suppose that's very conducive to mask wearing either. And then talk a little bit about the things that we need to do. So we have that problem. So how do we address that as public health entities, emergency medical services providers? Well, public health, again, I'll stress we have a very active governor in this process who is basically having everyday press conferences with the Director of the Department of Health Services. And last week, I believe it was Wednesday, perhaps it was Tuesday of last week, they announced a rollback of opening procedures. This includes closure of bars that don't serve food, closure of health clubs, water parks, movie theaters, and then one of Arizona's peculiarities is we have this. We actually have a river called the Salt River that runs through the northeast part of the valley. It doesn't. It dries up before it reaches central Phoenix, but there's this phenomenon of tubing regattas that people engage in when it gets really hot. And social distancing, masking is nowhere to be found at those things. So those were banned as well, much to the chagrin of pleasure seekers everywhere down here. So along with that, we instituted crisis standards of care, and there have been COVID-specific hospitals and convalescent facilities identified. here's where we get into civil liberties versus public health pursuits. We've had a couple of different health club chains file a suit claiming a non-friendly nature to businesses, Mountainside Fitness and Lifetime Fitness. These aren't national chains, but they're pretty sizable in the Phoenix area. There's 18 sites of the Mountainside Fitness with 90,000 members, and Lifetime Fitness is really dumped a lot of resources into their places, and they even have these lounges that are really shishi, and so the governor suspended their liquor licenses in a health club. Well, duh, I suppose you do that if people are misbehaving. So they're fighting that, and this is a war in the press. But the protests that we had down here, only one of the 13 cities, the largest protest cities, according to some Johns Hopkins data, showed a definite increase entirely attributable to the protests, and that was the city of Phoenix. I don't know if that's anything to be proud of. What other cities, I think 40 out of 50 states in the union are showing a rise in cases, and I think in many large cities are as well. But the Hopkins people think that there's explanations other than the protests in all but one city, and that's Phoenix. The crisis standards of care that were proclaimed last week. This was in conjunction with the director of the Department of Health, who chaired the committee looking at this. These crisis standards of care is a kind of a document they've had on the shelf for disaster preparedness. They dusted it off for this purpose and brought it up to date for the COVID pandemic. It offers liability protections for resource allocation and heightened emphasis on enhanced dispatch, alternative destination, and telemedicine. One of the things early on is that the director of the Department of Health Services requested that all agencies engage in what we call the treat and refer program in Arizona. You can think of this as training wheels for ET3 participation later, but it's an alternative care plan that not a lot of people were utilizing, but we were urged to do that. And this is enhanced urging to do that. The practical effect for the crisis standards of care in the EMS community are concerns about early discharges of patients. And this is, I'll just cite an example of things that are proposed, and supposedly it might be happening at a facility or two within the Phoenix area. COVID patients, we know, are in some cases happy hypoxics and tolerate low oxygen saturations. Well, if people are tolerating oxygen saturations of 85%, they're sent out with oxygen and pulse oximeters. And you know, in my estimation, that's kind of a seriously ill patient to begin with. And so our EMS folks are asking, well, when we get called 911 and a deterioration of such people, how are we to behave? Because the facility has already said we don't want them back by virtue of a misconstruence of these crisis standards of care. And so we have to tell our providers that we treat as if the past history doesn't matter. You've got a respiratory distress patient in front of you with low oximetries. You treat according to our COVID guidelines that heretofore have made the lower threshold of oximetries 88%, but now we may have to rethink that. But this constitutes a failure of outpatient therapy. If they're that critically ill, they got to go back to the hospital. and let them figure out futility care issues and what to do from that point. It shouldn't be an EMS community decision is what we're talking about. We have identified a facility, a recently closed hospital, to perhaps aid in COVID-specific treatment. There's also an Arizona COVID-19 surge line. This is kind of unique in that all the major hospital chains in the Phoenix area participate. It's supposed to be bi-directional, meaning that acute patients go to less well-equipped facilities, as well as the critical patients be transported from outlying facilities that go to the tertiary care hospitals. I don't know if in practice that is working as well as it is designed to, but they continually work on this COVID surge line. The Phoenix St. Luke's Hospital was shuttered for financial and demographic reasons back in December, but it was identified early as a possible place for COVID-specific treatment. And ever since that time, a multidisciplinary group of individuals has been working to bring the crumbling infrastructure back up to speed, and also to staff the place. They've talked about, is this going to be like a ventilator hospital with hyperacute patients, or is this going to be like a convalescent facility? I think the latest discussion is that it's going to be a little bit of both. They're having trouble staffing it, but supposedly they've got a nursing contract in place that's utilizing out-of-state recruits. The ESAR VIP program was looked at, and it was felt that there could not be verification of the capabilities of the people utilized through ESAR VIP. So that was not utilized perhaps as much as it could have to staff the place. Just a little bit about residential care facilities, and then I'll wrap up. We have an odd and peculiar reporting system regarding individual positive cases in our residential care facilities. There is actually no reporting system that is put forth by ADHS or the Maricopa County Department of Public Health. They only will, I don't want to get into the politics of the situation, but they will not identify facilities by name. They just take classifications and tell how many in raw numbers way, how many of those facilities do have cases. We've identified a workaround because these people are supposed to report positive cases to CDC and CMS, but a look at the data appears to be not helpful because known COVID hotbeds are reporting 0 cases to the CDC. So what we at Phoenix Fire and our municipalities have to do is approach every facility like the patient we're being called for is a patient under investigation for COVID. We wrestle with the facilities for proper ingress and egress for our paramedics and EMTs. We tell people that it would certainly help if the calls to just lift people off the floor and into bed, if the patient was clearly uninjured and not on blood thinners, if that would possibly be part of the sharing of responsibility in this scenario. But there was actually some pending legislation to kind of codify these suggestions, but it was legislature was adjourned before this could be dealt with. So in summation, again, I don't know how much this is things that you all deal with, or if your situations are even worse. But from my standpoint, I've learned a few valuable lessons during this. EMS is increasingly a public health discipline, and our interaction with the Department of Health Services and the Maricopa County Department of Public Health and the Department of Health Services has been a godsend for not just knowledge, but for transmittal of that knowledge to our EMS people to keep them confident that they're being protected as well as resources will allow in this pandemic. I firmly anticipate a conflict between public health doctrines and civil libertarianism, and I shudder to think about, and I'll just say it, shudder to think about anti-vaxxers and people that won't take the COVID vaccine when it becomes available. I think that is going to be a real public information blitz that's going to have to take place to get that mindset fixed. Reimagine traditional EMS concepts of dispatch triage, alternative care, nurse triage and dispatch centers, and my personal saying, and I'll stick to it, never let a good pandemic go to waste. What we've seen in our state is a relaxation of EMS scope of practice, drug box, training, and other rules just to maybe make our workforce more appealing to those that would come from without. And it's allowed medical directors, there's still supervision, it's dumped in the laps of medical directors, but it's still allowed for us to do things that we wouldn't have done under previous regulatory structure, and to open our eyes, expand the box. So with that, let me see if I can get this off. And
thank you so much, Garth. Appreciate that input.
Sorry if I ran long, but
Kevin, got it. Kevin, can you pull up your slides here and we'll transition to the Houston experience. Garth, there was a specific follow-up question that came up in the chat box. So, I'm sorry, in the question and answer box. If you could take a quick look at that. Great, thanks, Kevin. You're on.
All right, well, thank you, John. And just a little bit, thank you guys for the introduction, for giving us a chance to speak today. Myself and Dr. Chris Souter is going to give you a little insight on the Houston experience we're having down here, specifically from the medical direction standpoint, and very specifically to the Houston Fire Department. So I'm going to kick it over actually to Chris first to start us off. And let me see if I can advance the slides here.
Just want to make sure you can hear me okay?
We can, Chris. Thank you.
Excellent. Okay. So I'll say when we start is we have a lot of the same political personalities in Texas that Arizona has. And I thought what I would do is show you some very hyper-local effects on the fire department as a whole. And then that'll take just a few minutes. And then Kevin will talk about 4 or 5 specific areas that the medical directors have been involved with day-to-day actions in the fire department. So this is a good pairing along with Phoenix's information. And so this graph is showing our call volume weekly over the year, and yellow is 2020. And when the epidemic started, our call volume dropped 15 to 20%. You can see there where we opened up, and May 31st, you can see, and our call volume, and this is accurate as of yesterday, it took into account all of Saturdays, so that last point in yellow is yesterday's call volume. And so we're seeing a pretty significant increase in daily call volumes, which used to average around 900 or so EMS calls per day, and now we're at about 1,100 calls per day. Next slide. Back one slide. I think you went forward too. There you go. Oh, no, there you go, stop. And so this slide is looking at, so I hear lots of talk about how is our STEMI, how's our stroke, and how's our cardiac arrest volume affected during this time frame. And this is the same slide, only showing our patients that we consider dead on arrival. We did a resuscitation followed by a field termination and a non-transport, or our cardiac arrests that did get a transport to the hospital. And you'll see sometime in about week 13 or week 14 of this year, so the end of March, early April, it seems like 2020 has started to be significantly different than the prior 2 years. And so the next few slides look, and this is everybody's, so the next slides break it down. One slide forward. This is just our cardiac arrest transports, and you'll see that the yellow is, interspersed with our prior years. So it's not that we're transporting more cardiac arrest patients. Next. This is our field termination. So this is either a late presentation of a valid DNR, or our local protocol is 20 minutes of ALS care, and then if we do nothing, then a field termination with the medical director online. And you'll see that we've had some increase in this. And then our next slide, this is where our real significant difference is. This is the patients in arrest that meets our dead on arrival criteria of having either dependent lividity or rigor mortis. These are really dead people. We don't DOA, non-witnessed cardiac arrests. We don't have anything like that. So these are pretty hard categories, and these have gone quite up and are spiking right now, which is what's, I think, predominantly led to that increase we saw in our cardiac arrest stuff earlier. So I think that's pretty interesting. This calls into question whether or not people are having strokes and STEMIs and not going to the hospital, as some people are speculating, and then dying at home, and then someone does a welfare check, and then we get involved and we find them too late after the fact. Now, I did run our numbers for primary impressions of stroke and STEMI transports, and those do not show a separation in 2020, like, say, for instance, this slide does. So I don't have them here, but at least the numbers we're being called about with STEMIs and strokes haven't decreased, but we don't have quite yet any evaluation of what these DOAs are at a base level and why they're increased above our norm. And so those are sort of our main stats. I will point out, and I don't have a slide for this, that we have about 3,800 employees in the fire department. In terms of, we've had a big effect right now. You may have seen in the news, we're having a hard time staffing. There's some political issues. Dr. Schultz, do this for me. Yep. So we have a lot of people that have been quarantined for a period of time, actively quarantined, up into the upper 260s. Out of our 3,800 members, though, only 148 have resulted in a positive test. The active quarantines come from what we judge to be medium risk exposures that gets called into our infection control group, and Dr. Schultz will talk about that. But so those are sort of the information. We've had only 2 or 3 people hospitalized, 1 person in the ICU, no members died. So hopefully that will continue that way. And so that's sort of our effect on our day-to-day operations. I'll let Kevin then take over and go into 4 specific areas where the medical directors got involved.
Thanks, Chris. So just a couple of things to come up with. I mean, certainly, first and foremost, obviously medical direction involved with writing protocols, and we've done what I don't think is particularly novel a lot of places, minimizing aerosol generating procedures, things like that. So I didn't get too deep into that. We really went over the things that were more kind of unique and new for us in terms of our roles. And this is kind of the brief breakdown of the 5 slides I have here. So just to kind of keep moving. So our infection control office, when this whole thing started, we had a single full-time civilian, and she had some assistance from some temporary assignment classified personnel. When you're looking at over 4,200 suspected exposures called in with over almost 1,000 quarantines over the course of this thing, that's obviously not going to work. And early on, the assistance actually came from Dr. Souders and myself. Several of the doctors got involved in terms of actually taking the infection control calls, the evaluations. As we staffed up the office, really we shifted over towards dealing with infection control policies and interpretation of CDC guidance. As everyone on the call I'm sure knows, the CDC guidance has been at times a little bit vague throughout the course of this process, and is, you know, in order to be adaptable to many areas and many agencies, so we had to interpret it into our process, into our infection control area. So that's one piece that we were involved quite a bit with, and still are to this point. Currently looking at, you know, policies about when we quarantine, what we do as far as exposures at the fire station, because as far as our system, the fire-based EMS, our members are on 24-hour shifts, and it's like a household. And early on, CDC said quarantine the household if one person gets infected. With 148 members infected, that certainly involves lots of quarantines. So we've been kind of involved in some of those decisions. We've had to create some novel education pathways to the field. Like as with Phoenix, you know, a lot of education going out, a lot of things going out. We have an existing website where our protocols are housed. We actually started creating a video message, short 7-10-minute videos, and we were doing them daily for a while. We did almost 6 weeks of daily videos, and eventually we've decreased the frequency. We're still doing them. Now we're down to about once a week. But they were generally medical direction, driven by questions from the field. And actually the fire department put out a general order requiring at the beginning of the shift that they watch these videos. This was a new way we were able to get information out. We also consolidated all our COVID-related correspondence, including all the memorandums about changes in the fire department and all of our training videos, into one place on this website to try and give the department a one-stop shop on where to go get their information. As far as testing, I saw a question on the chat earlier about, you know, standing testing. Certainly with the spike happening here, we've not been able with 3,800 members to do standing testing of our personnel. But we do have processes in place for when a exposure or when a symptomatic patient calls into infection control. And we kind of used a multimodal approach where we tried to stick with the city and state sponsored drive-through testing centers. Walgreens has a bunch of couple of testing sites up here, as well as freestanding ERs, though we did secure through Baylor College of Medicine our own testing kits, trained some of our own personnel to do that. We've only run 10 of those tests, but we've been reserving those for people we either couldn't get into one of the other testing resources, or some very specific situations, including some back to work issues. And so we had some of our personnel trained up to collect those samples, and we get them to Baylor for testing. And I know I'm going fast here. We can certainly talk about it at the end, but I just want to kind of get through these things for y'all. We did create a nursing home and high-risk facility task force that was driven through the fire department side. We were involved more on the consultant side, dealing with how to set some of this stuff up. There was a joint task force with the Houston Health Department. Initially, it was developed to provide education to nursing home personnel, and a joint task force of HFD personnel and health department personnel went to the facilities and just gave education on PPE, on proper isolation standards, and they visited 218 facilities in that first round. Later in the process, in April, I believe it was, the governor of Texas put out an order saying that we needed to be testing all nursing home and certain high-risk facilities, at which point this task force, these personnel were transitioned to a testing role where they were trained, and they actually went out and did some tests, similarly in conjunction with the health department. And that's something that still is in effect and can be utilized going forward. They're not currently running, but at the moment, but I believe that they're still on standby and available. And then finally, the fire department also put together a decontamination task force in conjunction with the hazmat team. It's not hazmat members, it's general members, but we have 93 fire stations, and each one was hit multiple times, and they are still in operation. They've got 8 fire stations on the schedule for today for decontamination. We've also used them to decon apparatus after certain high-risk transports and situations. Again, we weren't really directly involved in the development of that process, but we were consulted in terms of CDC guidance on terms of what type of decontamination. And as the science has changed over the course of this pandemic of, it lasts for 3 hours on a surface to 17 days to a couple of days, and all the various things that have come out of the science side, we've been involved in those processes as well. And I know I went quick, but I wanted to make sure we got through and gave time for questions, and just wanted to give you guys some brief updates on what we had done from the medical direction side here in Houston to try and kind of come up with innovative solutions for the pandemic response.
Thank you, Kevin and Chris, both of you, for that information. For purposes of the panelists and the audience, we're going to forego the polling questions this week. We had several polling questions that we were going to repeat from a previous session, just so that we can look at some trends over time. We'll see what we can do to potentially incorporate some of those in next week's session as well, just so that we can continue to look over time. For Kevin and Chris, we'll start out real quickly and then go to the panelists. And panelists, get ready. If you have a question or comment, please either unmute yourself or raise your hand and we'll go over to you. One of the follow-up questions had to do with the increases in cardiac arrest and dead on scenes that you noted in one of your slides. Was that an increase in deaths overall, or potentially an increase in the use of EMS as opposed to other resources like nursing home physicians or funeral homes who would otherwise have been notified in some of those events?
I can't say that I've individually gone in and looked at those. We don't have a real community practice of calling funeral homes directly. So I can't imagine that is a lot of that. I think that our call volume has gone up, but our number of patients transported just for all causes has not gone up. It's stayed in the 340 to 370 transports a day, which is what it's been for years. And so I think that there is something unique about, our call taking process, other than asking screening questions to alert the fields, hasn't changed in terms of who we send and to what we send for. And so I think there is something unique about it, but the cause of it, I don't know for sure.
Great, thank you. Questions or comments from panelists? Before I go ahead, Doug.
Sorry, mute issue. If this is for Chris or Kevin, you talked about, obviously a huge EMS workforce, and you talked about the sort of family structure of a fire department and quarantining within the department and that sort of thing. But my question is, what have you been doing outside of quarantine type of thoughts with those providers? We have, and I've seen systems where they're treating the EMS providers like people within the hospital, and they are wearing masks during their entire shift when they're in the vehicle with their partner, and when they're not on calls, when they're in the station, et cetera. And I've seen other agencies where as soon as the call is done, they're back in the ambulance, the two of them, like their family members, are back at the station without any PPE. And we know how essential PPE is to this. What are your rules for, hanging out at the station, work shifts, in the vehicles, that sort of thing?
So there was a general order. Thank you, Doug, for the question. There was a general order put out in the fire department that they are supposed to be wearing a surgical or cloth face mask at all times at the station, in the vehicles. And then the transition, because like Garth mentioned in Phoenix, we have to treat everybody like a PUI. When they make patient contact, they switch to an N95 if they're going to be within 6 feet of that patient. Now, there's certainly a variety of some stations are, some people are maybe a little more compliant with it. There's certainly the question of sleeping with the 24-hour shift and people sleeping with masks on. That has come up. But the general order is that when they're in the station, unless they are truly social distanced, out in the parking lot or something, that they are to be wearing a cloth or surgical mask at all times.
Carol?
I had a question for Garth. Concerning the fact that your state is not reporting positive cases in facilities, and you're treating everyone as if they're a PUI, has that challenged your PPE resources? Because I would imagine you would be going through a lot more, when people complain of a fall or a hip injury or whatever, and you're treating everyone as a PUI.
Well, Dr. Cunningham, that's a real concern nationwide, is kind of what's called COVID fatigue syndrome, especially in those areas where the peak was hit and then the cases dropped precipitously. How do we keep our people from getting an improper message that they can now kind of relax their PPE? So we've been fighting that because we never really peaked. We don't have quite that amount of problem. Plus, our Maricopa County Department of Public Health and our departments made great efforts to, this is a bad word, but stockpile PPE. It's not as bad as it sounds because we've also been using systems like the Patel system to recondition our N95 masks. We've been making gowns out of plastic picnic table coverings. They've been doing a lot of stuff. There's a fellow that takes care of people on the Gila River Indian Reservation that's fashioned his own ventilators and is making his own ventilators out of stuff you buy at Home Depot, I guess. So, a lot of things we're doing to try and keep our people clothed, but the bottom line is everybody is potentially infected in the residential care facility when we don't have good numbers.
Quick question for either Chris or Kevin from Houston. You talked about one of your nursing home task force, I think, transitioning to doing some additional activities, including testing. I'm assuming that is collecting the samples from the nursing home or patient population. There's been a little bit of controversy about that around the country. Some folks have concern about EMS being involved in that. Some public health agencies have concern about EMS being involved in that. How was your transition to that capability? How did that come about?
So we had initially, there was talk that the governor was going to put out the order saying we had to test all these facilities, and so the fire department tried to get a little bit ahead of that in terms of creating these task forces and working with the health department. In reality, most of the testing that they did was not, and a sample collection, as you mentioned, as you kind of assumed, was actually not in the nursing home. So there were several different agencies and entities that helped with collecting nursing home samples throughout the Houston area. So actually, when the governor put the order out, we didn't have to do a lot of nursing homes from the fire department standpoint, but we did go into several high-risk facilities, including long-term, group homes and some rehab facilities. And so it kind of came about in the sense of they weren't necessarily immediately required in the order, but it was something where we wanted to get a handle on hotspots. And so the fire chief was pretty adamant about kind of moving forward with that. So there wasn't a ton of significant pushback on this side. It certainly was a conversation, though, because there was some concern about that. These members were working on overtime and bringing people in. And so obviously full PPE. So there were several considerations we had to think about, including our PPE stockpiles, including our ability to, you know, bring people in on overtime, which when we did this more in the April and May timeline, our workforce was a little bit stronger than it is right now. We didn't have quite the spike of either people calling out or people quarantined that we do at the moment. But it did work out for us at that point.
The only other thing I would add is our real boss, Dr. Peirce, who many of y'all know, is also the public health authority for the city. And so because we were combined with the health department, there was never any question about, is it okay for EMS providers to be taking samples or to be doing the testing? If that was part of your question, there was never a, you know, this isn't their role, or they're stepping outside their lane or anything like that.
Thank you. We're running up to our time. Any final questions or comments from any of the panelists? All right. If not, really like to thank Garth and Kevin and Chris for sharing your experiences with us today. The panel for your thoughts and questions. Bruce and your team for continuing the great job with the platform that we're using. And for all of the audience participants who shared their thoughts and comments, either as questions or information sharing in the chat box. I thank you all. Have a great week, and we will see you next Monday.
Thanks, everyone. Have a good week.
Thank you.